to be to review sonographic findings of trisomy 21, discuss associated anomalies of trisomy 21, discuss the different classifications of atrioventricular canal, discuss our case study, review patient imaging, and review patient's surgical repair.
So to start out, we're just going to ask if anyone knows what the definition of trisomy 21 is.
It is having a third copy of the 21st chromosome.
Yep, good. So we define it as every cell within the body has 3 copies of that 21st chromosome rather than the 2 copies. And then we just have an image here showing the 3 sets of the 21st chromosome there. So trisomy 21 is the most common chromosomal disorder. There's an incidence of 1 out of 700 live births. The prognosis is dependent on associated abnormalities, and the usual life expectancy is around 60 years old. The major cause of infant mortality is congenital heart defects, and then the major risk factor of trisomy 21 is advanced maternal age, which is over the age of 35 years old.
So going into the diagnosis of trisomy 21, we usually start with some screening techniques. So first, there's the nuchal translucency. Does anyone know what that is and what the normal measurement is?
It's 3 millimeters.
Yep. Good. So you have less than 3 millimeters, and that's just the measurement behind the fetal neck. This is usually done between 11 weeks to 13 weeks, 6 days. There's also a quad screen, which is a blood test that's conducted during the 2nd trimester, usually 15 to 22 weeks. This is used to identify pregnancies at a higher risk of chromosomal anomalies like trisomy 21 and also 18, and then also neural tube defects. And these are looking at lab values of AFP, estriol, HCG, and inhibin A. So those were just some screening uses. There's also genetic testing that is used to confirm. So there's amniocentesis, which is performed as early as 12 weeks, but ideally between 15 to 20 weeks. There's chorionic villi sampling, which is usually done 10 to 14 weeks. And then there's also chordocentesis, which isn't used as much anymore, but this is done after 17 weeks. And then this is just showing an image of a normal nuchal translucency thickness. Here is where we would do that measurement. And then here you can see this is increased, and that is common in fetuses with Down syndrome.
Some associated anomalies of trisomy 21 include an increased nuchal fold, which is typically measured around 20 weeks. An abnormal nuchal fold is considered over 6 millimeters. Limb abnormalities that are associated with trisomy 21 include short femurs or humeri, hypoplasia of the middle phalanx, clinodactyly, and sandal gap. GI defects that are associated include duodenal atresia. We see this in about 30% of cases, and then echogenic bowel as well. Some associated heart defects include atrial septal defects and ventricular septal defects, and echogenic intracardiac foci, which this is a soft marker that doesn't always mean that the baby has trisomy 21. It can be an isolated finding as well. And then another associated heart defect includes atrial ventricular septal defects, mild ventriculomegaly, patent ductus arteriosus, and tetralogy of Fallot. And then other prominent findings include myelopylactosis and absent nasal bone and intrauterine growth restriction as well. And a lot of these are found at or after the 20 weeks of gestational age.
So going into some images that can be found with trisomy 21, does anybody have any clue of what this is showing? This is of the fetal abdomen. We're mostly looking at this area here. So,
Echogenic bowel.
yeah. So to confirm this, usually what you can do is you can turn down your gain and then compare that echogenicity to the bone echogenicity. And then this image here, does anyone know what this sign is called? This is of the abdomen as well.
The double bubble sign.
Perfect, yep. So this is seen with duodenal atresia, and this is the double bubble sign here.
Going into some more of the sonographic appearances that you can see with trisomy 21. To start with this image on the left here, we're looking at that increased nuchal fold in the back of the neck. Does anyone remember what the abnormal measurement for this is?
Less than 6 millimeters.
Yep, it'd be actually greater than 6 millimeters, but good. The image on the right is showing that clinodactyly, so you can see that fifth digit is showing curvature of the finger there.
This image here is showing the fetal kidneys, as you can see here, and these measurements are showing that the pelvis is dilated. So when the renal pelvis measures more than 4 millimeters before the third trimester, that is considered pylectasis. And then after the third trimester, when it measures more than 7 millimeters, that is considered pylectasis.
So going into the atrioventricular canal defects, like we said earlier, it is associated anomaly with trisomy 21. It's also known as an endocardial cushion defect, or as a lot of people know it as AV canal. It is the most common associated cardiac anomaly with trisomy 21. It's actually seen in about 50% of patients with trisomy 21. There are several different categories, and it does consistently consist of 3 defects, which is a primum ASD, an inlet VSD, and a common AV valve. So going over some of the different types, there's partial, transitional, intermediate, and complete. Starting with partial, the baby's going to have a primum ASD with no VSD, and there's going to be 2 separate orifices. Transitional, there's going to be a primum ASD with a small inlet VSD and 2 separate orifices. Intermediate, it's going to have a primum ASD, a large inlet VSD with 2 separate orifices again. And the complete is the most severe type. It is a primum ASD, a large inlet VSD, and 1 common valve. And with partial and transitional, they have similar physiologies to that of an ASD, whereas intermediate and complete have similar physiologies to those of an ASD and VSD. So going over some of those types again, here are just some pictures representing them. So does anyone know what this first picture here is? The first one on the left?
Common AV valve?
Yep. So this is going to be the complete form of AVSD. So it has a common AV valve, an ASD, and a VSD. Does anyone know what the second one is?
It's an intermediate AV canal defect.
Yep, good. So this one's intermediate. It does have the ASD and the VSD like the complete does, but you can see there are 2 separate orifices here, whereas the complete has 1 common valve. So good. And then moving on to this next picture.
Transitional.
Yep, exactly. Yep. So in this case, there is a smaller VSD, 2 separate orifices, and the ASD, like we said before. And then this one here.
Partial?
Yes, partial. So there's only an ASD, there's no VSD, there's 2 separate orifices. And this is going to relate the most to our case specifically. So just kind of keep this one in mind.
And then to talk more about a care plan for patients with trisomy 21 and the AV canal, they usually recommend a fetal echocardiogram, a serial echocardiograms after birth, and then surgical repair as well.
Now moving on to our actual case study. So the mom in our case, she is of advanced maternal age. So like Katie said, that's older than 35 years old. This is her 4th pregnancy, and she has had 3 live births previously. And she did have an abnormal quad screen, so that showed a risk of trisomy 21. And it was a singleton pregnancy with an expected due date of 11/1 of 2021.
Going on to the exam history. So the baby did have a quad screen completed, which that's how they suspected trisomy 21. They also had a growth ultrasound done, but because intrauterine growth restriction can be a finding in babies with Down syndromes, but all findings were within normal limits. So we did not include that in the imaging history. After birth, actually, they had a fetal echo done first at 27 weeks where AV canal was suspected, since that is such a highly associated anomaly with patients with trisomy 21. And then a pediatric echo was done after birth. So they had several pediatric echoes, surgical repair, a post-op TEE, and a post-op transthoracic echo as well.
To go into the targeted fetal ultrasound more, this was performed at 19 weeks. This patient did not have an initial dating ultrasound for this pregnancy. It was based off of her last menstrual period, which was in January of 21. So this was considered a targeted ultrasound because of the advanced maternal age and then the abnormal quad screen. This is where they'll look at the full anatomy of baby, and everything that was evaluated appeared normal except for the 3 abnormal findings I have listed here, which include that absent nasal bone, a bilateral echogenic focus within the ventricles, and a possible ventricular septal defect as well. So some images from our case study. This is showing the absent nasal bone. So you can see here the bone in the forehead, and it's not continuing. And then we did have a cine clip as well showing that right there. And then a couple more images from the ultrasound showing that echogenic focus in both of the ventricles. You can see here, and then in the cine clip, it shows it well also in the ventricles. And again, this is considered a soft marker because babies can have this that don't have trisomy 21, so it's considered an isolated finding at times as well. So with the results of the quad screen, these findings were consistent with trisomy 21. The patient did return for genetic counseling and full maternal fetal medicine consultation. So a fetal echo was recommended. Serial fetal growth was also recommended. So the growth was performed to confirm the estimated due date and make sure that the results were consistent with the targeted ultrasound. And then although intrauterine growth restriction is associated with trisomy 21, this baby specifically had a normal growth with an estimated fetal weight at the 58th percentile. They also did an antepartum fetal surveillance as well.
So going into the fetal echocardiogram, this was performed at 27 weeks, 3 days. They found all velocities, measurements, and z-scores were within normal limits within this exam. There was, however, an incomplete endocardial cushion defect. So with this, they saw a moderate inlet VSD, a cleft mitral valve, and they did note that a tiny primum ASD may be missed just with the limitations of ultrasound. They also saw a common AV valve with trivial regurgitation, and there was also an aberrant right subclavian artery, which Shelby will go more into. So this video here is showing the VSD. As you can see here, it's just not continuous here with this septum. And then in this video here, this is showing the valves are at the same level. So this is another reason why they thought it may be an AVSD, just because usually you see that common valve. So this is showing, again, the valves at the same level. And this is showing a sweep through of the heart, showing the crossover of the vessels. You can see the color crossing over the septum here in that beginning. So that's again showing that VSD right there. And this is showing the cleft mitral valve. You can see right here. And then I have another video here. Pause this one for now. Oop. So here you can see right there. And then in this video, it shows it pretty well right there. You can see that flapping is just not continuous. So there's the cleft.
So after birth, an echo was recommended. So in this echo, they did see a partial AV canal. It is a different finding from the fetal echo, but it is hard to see the primum ASD in a baby in the fetal echo because of that PFO. So they thought maybe that could have been missed. But in our after birth echo, we didn't see that. We just saw the PFO still there. There was a moderate paramembranous VSD with a cleft mitral valve that was also seen with mild regurg. And aberrant right subclavian was also seen on the fetal echo and was assessed with pediatric as well again, even though they called it, like I said again, it can just be missed. So with what these findings have in the baby having trisomy, they still did call it partial AV, even though there technically was not an primum ASD. So this video here shows the VSD, and this is on the pediatric echo. So you can see this red flow right here, shunting. And this is in the parasternal long axis view. Here again is a video of the cleft mitral valve. You can see this regurgitant jet going right down the center. And that's right where the cleft is. And then here's just a Doppler proving again that it is mild to moderate. Here again is the cleft mitral valve in the parasternal short axis view. This one is just a still image showing where the cleft is. So it's that, like Kenna said, that discontinuation. So you can kind of see where it splits here. And then here's a nice cine of it. You can see opening right there is where the cleft is, and it is in the anterior mitral valve leaflet. So moving on and talking a little bit more about the aberrant right subclavian with a left aortic arch. It is a rare anomaly where the right subclavian artery originates from the aortic arch rather than branching off the brachiocephalic artery. It is seen in about 0.4 to 1.8% of people, and it is typically asymptomatic. It is the most common arch defect seen with patients with trisomy. They are 35% more likely than the average population to have this anomaly. Like I said, it is most likely asymptomatic, but sometimes it can be associated with dysphagia because sometimes this aberrant artery can pass between the space of the esophagus and the vertebral column, or even between the gap of the esophagus and the trachea. So like I said, just it can cause some dysphagia because it restricts swallowing. Here's some pictures this is from the fetal echo. So this is called the 3-vessel view. In this view, typically you just see the pulmonary artery, aorta, and the SVC. So this image on the left is from our study, and the image on the right is a normal image. So what we should see is the pulmonary artery, the aorta, the SVC, and this is just the trachea here. And in our image, you can see this red flow going up, and this is the aberrant right subclavian. So it is pretty obvious when there's one there because you shouldn't really see this flow at all. So some surgical repair that was done, there was closure of the paramembranous VSD defect with a 0.4 millimeter Gore-Tex patch. There was a valvuloplasty of the mitral valve with complete cleft closure through the transeptal approach. And there was also a complete PFO closure. The baby did go into complete heart block, but then was paced at about 150 beats per minute. And the aberrant subclavian doesn't need to be fixed because it wasn't causing any problems, which is pretty typical. So here are just some pictures of what those surgical repairs look like. So for the VSD, they typically take a patch and put it over the hole, and it's just sewn into the ventricular septum, which can cause wall motion abnormalities after birth or like a low ejection fraction. And then here is the cleft mitral valve. This is what it looks like before surgery. This is what it looks like after. So they put the patch over and sew it in. And this is actually the anterior mitral valve, which was fixed on our case as well. And just another view. It's a little easier to look at it in pictures like this than in an echo. So I thought it'd be nice just to show you guys what the repairs look like. So post-operatively, they did a TEE. The TEE showed good biventricular function, no VSD, no ASD, no significant tricuspid regurgitation, and mild mitral regurgitation. Then a postoperative echo was done. The one we looked at was done 4 days after surgery. There was moderate mitral regurgitation, a tiny residual VSD with left to right shunting, and an ejection fraction of 37, which is low. Normal is usually from 55 to 75. But this is pretty normal after surgery to have a lower ejection fraction, especially with a VSD closure. So in conclusion, our baby did have mild to moderate MR, which stands for mitral regurgitation, a decreased ejection fraction, and was discharged.
So we just wanted to say thank you to Meriter Hospital and American Family Children's Hospital for sharing these images and case information for this report. We also wanted to say thank you to Mindy Vanderleest and Lindsay Thomas for helping us set up this presentation and getting those images for us as well. And thank you to everyone for listening.
Is there any questions? And here's our resources.
All right. Well, if nobody has questions, I'll stop sharing.
Thank you guys so much. You did a great job.
Thank you.
Yeah, no, that was really good. So just real quick reminder for everybody, if you can make sure to put your first and last name when you log in. If it's any of the students, don't, I mean, obviously you don't have to worry about it, but anyone who is seeking credit, I need your first and last name just for attendance purposes, okay? And then the next ones, is it going to be Megan and Elizabeth with COVID in the heart? Or did another group plan to go next?
In school, we talked about Becca and Autumn, but if you would like us to go, we can.
Nope, that works. It was just going off the email.
Okay.
Yep.
I'll try and share my screen now.
Yep. Okay, so Rebecca and Autumn, they'll be doing anomalous pulmonary venous return. And then another quick reminder why they're getting set up is the link for the CME survey that has to be filled out. That is in the chat. So anyone who needs that link, it will be in there. Just make sure you have full name, any ARDMS number that you might have, and of course your birthday. And then whenever you ladies are ready, go right ahead.
All right, can everyone hear us okay?
Yep, you sound good.
Alrighty, so my name is Autumn Carlson.
And my name is Becca Sabourin, and we are echovascular seniors.
And today we're going to be talking about anomalous pulmonary venous return.
Our objectives tonight are to describe the etiology and incidence of anomalous pulmonary venous return, discuss the signs and symptoms, differentiate between total anomalous and partial anomalous pulmonary venous return, identify the anatomy that may be seen on echo, discuss the signs and symptoms, identify and review associated defects and differential diagnoses, discuss associated defects and complications, and review pre- and post-surgical case study images.
So to begin with etiology and incidence, about 9 in every 100,000 births have total anomalous pulmonary venous return present. About 400 to 700 in every 100,000 births have partial anomalous pulmonary venous return present. About a third about 1.6 to 2% have a third pulmonary vein present, so that could be a third right or a third left pulmonary vein. And about 3 in every 100,000 births have core triatriatum present along with it.
So moving on to signs and symptoms, this consists of having a weak pulse, being cyanotic or having blue extremities, failure to thrive, tachypnea, tachycardia, and a murmur. And a murmur for partial would be a wide split fixed S2 and a systolic ejection murmur that is usually heard at the left sternal border. Whereas with total anomalous, it's a fixed split S2 systolic ejection murmur.
So moving on to different types of anomalous pulmonary venous return. There is total anomalous pulmonary venous return, which is when all of the 4 pulmonary veins do not connect to the left atrium. And then there is partial anomalous pulmonary venous return, which is anywhere between 1 to 3 of the pulmonary veins not connecting to the left atrium.
So getting in on total anomalous pulmonary venous return, it's a rare cyanotic congenital heart defect where all oxygenated blood from the lungs do not return to the left atrium. A PFO or an ASD is necessary because you need it for the blood flow to mix and get to the left heart and oxygenate the baby's body. There are 4 different types. That would be supracardiac, cardiac, infracardiac, or infradiaphragmatic, and mixed.
Alrighty, so can anybody tell me what image A is showing?
Supracardiac?
Yep, so that is supracardiac. So that is when all 4 pulmonary veins confluence behind the left atrium but don't connect, but they actually connect to a vertical vein that connects to the innominate vein that connects to the superior vena cava into the right atrium. Does anybody know what image B is showing?
Cardiac type?
Yep, so that's the cardiac type. So that is when the confluence of the veins actually connect to the coronary sinus and drain into the right atrium. What about image C? What is that showing?
Infracardiac?
Yep, so that is infracardiac or infradiaphragmatic. So that is when the confluence of the veins connect behind the left atrium but don't connect to the left atrium, and instead they connect to a vertical vein that drains into the IVC, which drains into the right atrium. And then finally, does anybody know what image D is showing?
Mixed types?
Yep, so that's the mix. So this can come in many different variations. This image just so happens to show that the right pulmonary veins are connecting to the coronary sinus and that the left pulmonary veins are connecting to the innominate, which drain into the superior vena cava. So none of those veins are connecting to the left atrium.
So moving on to partial anomalous pulmonary venous return. It's also a rare congenital heart defect where some but not all of the pulmonary veins connect to the left atrium. An ASD may be present and it's usually a sinus venosus defect because of the malposition of the septum primum. And as you see in this corner, you will see something called scimitar syndrome, and that is where the right pulmonary veins drain into the IVC and then drain into the right heart. And this is known for hypoplastic right pulmonary artery and a hypoplastic right lung. and because of that, the cardiac structures may be displaced.
So this is just showing different variations of partial anomalous pulmonary venous return. It can be a number of different things, but just for examples, image A is showing that the right pulmonary veins are connecting normally to the left atrium, but the left pulmonary veins are connecting to the innominate vein into the SVC. In image B, this is showing that the right pulmonary veins are also connecting normally, but the left are connecting to the coronary sinus and draining into the right atrium. And then image C, again, is showing that scimitar syndrome, which is where the left pulmonary veins connect normally to the left atrium. However, the right pulmonary veins are connecting to the inferior vena cava. So a little bit on sonographic appearance. So what you're going to see on an echo. So with total anomalous pulmonary venous return, you're going to see right atrium enlargement. You're going to see right ventricle hypertrophy. You will also see an increased pulmonary circulation through that right side. You may also see a right to left shunting if there is an ASD or a VSD present. You may also, and you will see that the pulmonary veins do not connect normally to the LA, and they also could be obstructed. There may be a vertical vein present in some cases, and then you may also see septal flattening, which will be due to the volume overload, which will eventually turn into that pressure overload. With partial anomalous pulmonary venous return, you may be able to confirm it with a bubble study if there's a persistent left SVC, which there may be left pulmonary veins connecting to. And if you do that agitated bubble study in the left arm, you will see the bubbles flow into the coronary sinus first. You may also see an ASD or a VSD present. You may also see right atrial enlargement, and arrhythmias are a pretty common thing with partial anomalous pulmonary venous return. Some specific things you want to look for with an echo is you want to assess for the pulmonary vein obstructions. So you want to make sure there's no sort of stenosis that can be causing that high velocity flow or backing up of blood into the lungs. Another thing you really want to look for, especially in total anomalous pulmonary venous return, is you want to look at that interatrial septum. You want to see that there's an ASD because you want that mixing of blood to get to the left side. If there is not, and it's an emergent case, there may be a balloon atrial septostomy that might be performed, and that is basically when a catheter is fed into the heart and across the atrial septum, and a balloon is blown up on the other side and then is violently pulled across the septum to make a giant ASD. Another thing you want to assess is the pulmonary vein connections. So you want to see where these veins are exactly connecting. Are they connecting to the LA or the RA? And then finally, you also want to assess where these veins are draining. So let's say they're connecting to a vertical vein. You want to make sure you want to see where that vertical vein is draining.
So moving on to pulmonary venous obstruction, the first image here is showing a normal pulmonary vein waveform. So as you see, there's high velocity in systole, then yet again in diastole, just a little bit less velocity. And then as you go on, you will see a normal retrograde wave. Then as you move into this image, it looks a bit different, obviously. So you'll see that it's more high velocity, and there's a loss of phasicity, loss of spectral window, which can also be because it's turbulent, but in this case, it is caused by a discrete stenosis.
Some associated syndromes and complications that can occur with anomalous pulmonary venous return is Turner syndrome. So that is most commonly with partial anomalous pulmonary venous return, and this is a genetic disorder that primarily affects females where there's a loss of an X chromosome. Next is Noonan syndrome, which is another genetic disorder that is pretty common with partial anomalous pulmonary venous return. When you look at total anomalous pulmonary venous return, a syndrome that's pretty common is heterotaxy with polysplenia, which means the person has multiple spleens, or asplenia, which means the person has no spleen. Some complications that can be present can be arrhythmias. You may also see congestive heart failure. This tends to be a later symptom for partial anomalous pulmonary venous return due to the fact that partial anomalous pulmonary venous return can go undiagnosed for a while, and congestive heart failure tends to be the first symptom present. But normally with total anomalous pulmonary venous return, this shows up right away. You may also see pulmonary hypertension and hepatomegaly present, which is that enlargement of the liver.
So now we're moving on to our case study. And our patient has anomalous pulmonary venous return with core triatrium sinister. And there is a reason that we didn't specify which anomalous pulmonary venous return it is.
So going on to patient history, our patient presented to the ER of Children's Hospital of Wisconsin from an outside hospital. They were a 40-day-old infant who was intubated. How they presented to the ER was they were in cardiogenic shock. They had increased fussiness, poor feeding, blood was present in the urine, and they also had cyanotic or blue extremities. Upon a physical exam, they determined that the child had tachypnea, was tachycardic, was also hypoxic, and as they listened, they heard a grade 2 systolic ejection murmur heard at the left upper sternal border, which is a murmur of anomalous pulmonary venous return.
So still on day 1, Children's got the echo from outside, and it showed likely obstructive TAPVR with severely dilated right ventricle that was also dysfunctional. And then they also saw increased pulmonary artery pressure. And this kiddo was put on emergent venous arterial ECMO because their CO was unresponsive. However, once they were put on ECMO, their O2 stats quickly began to improve. And in a situation like this, you need to act quick because you need to reduce the afterload on the right heart and not go into congestive heart failure.
So this is some of the images from the outside hospital that Children's was able to have sent over. So for example, in this first image, this is what is normal. So this is a suprasternal notch view, tilting down towards the left atrium, known as the crab view. In this second image, this is showing the vertical vein connecting to the innominate, which connects to the SVC to the RA. This is something you don't want to see and is abnormal. You are also seeing that all 4 pulmonary veins, which should be connecting to the left atrium, are not, and there's no direct connection. So more history on our patient. Children's Hospital of Wisconsin and Milwaukee decided to perform their own echo as well, and they planned to stabilize the patient overnight and operate early that next morning. What the first echo showed was a right upper pulmonary vein, right lower pulmonary vein, and a left lower pulmonary vein confluencing together, but they could not find where these veins drained. They also found that the left upper pulmonary vein connected to a vertical vein, and that vertical vein had severe obstruction. They were kind of debating about how to diagnose it or decide what the first echo showed. So what they first thought was it was core triatriatum with a levocardiocardinal vein or a vertical vein, or they were deciding whether it was core triatriatum with supracardiac total anomalous pulmonary venous return. During this echo, the patient was still on ECMO, and they noticed that there was an improved systemic perfusion.
So the prognosis for anomalous pulmonary venous return. Untreated total anomalous is fatal within the first weeks of life because the body is not being oxygenated. And with partial anomalous, it can be asymptomatic, like Autumn said earlier, and it can lead to congestive heart failure, and that tends to be the first symptom. And for surgical intervention, it usually results in normal blood flow circulation. And according to Mott's Children's Hospital, surgical mortality is less than 5% when it is repaired electively in a healthy child with unobstructed pulmonary veins. But unfortunately, this is not the case for our patient. Obstruction of pulmonary veins can occur and cause arrhythmias. And the pulmonary vein obstruction after repair is difficult to treat and has a mortality of about 40% over 3 years. because they already messed with the pulmonary veins in the first place and they had to reanastomose them to the left atrium. So going in again would be difficult.
So these are some images from the first echo that Children's Hospital of Wisconsin performed. First image is that apical 4 chamber, which you can see a large right ventricle, which is also severely hypertrophied, and you can see a very thick moderator band present. You will also see a severely dilated right atrium as well. And if you take a look over to the left side, you will see kind of a membrane in that left atrium, and they determined that that was cor triatriatum sinister. In the second image, you are seeing your short axis view, which is showing at the papillary muscle level. So you can see how large that right ventricle is and how it is basically compressing the left ventricle in both systole and diastole. So that is showing that there is a huge volume overload present along with very high pressures on the right side.
So moving on, you probably want to know what a cor triatriatum sinister is. And this is something that divides the left atrium into superior and inferior chambers. So you have an obstructive membrane in between the left atrium. So you have the superior chamber, and then you have the membrane and the inferior left atrial chamber as well. So the blood comes in and has to flow through the pulmonary veins and go through the membrane just to get to the left ventricle.
To go into a little bit more detail on what cor triatriatum sinister is, PET echo's definition is cor triatriatum sinister is a rare congenital heart defect in which the left atrium is divided by a fibromuscular membrane into 2 chambers. So this fibromuscular little membrane can be restrictive or unrestrictive. You want it to be unrestrictive because you want free flowing blood flowing through that left atrium. If it is restrictive, this can be a problem, and it tends to mimic mitral stenosis. This congenital heart defect occurs in about 0.1 to 0.4% of all congenital abnormalities reported, and it is often associated with a bunch of other cardiac abnormalities, such as a PFO, a secundum atrial septal defect, a bicuspid aortic valve. It can also be present with a left superior vena cava connecting to the coronary sinus. And of course, it can also be commonly associated with what our presentation is on, anomalous pulmonary venous connections.
So moving on to the echo images here, you see in that first image, it is the same image we showed earlier, but it is showing all 4 venous connections. And there looks to be some turbulence on the left side here. So that would be an obstructive confluence for the left pulmonary veins. In the image on the right, you see the red flow in the bottom right here. That looks to be the right pulmonary vein connecting to the left atrium normally.
In this first image, this is showing color over that cor triatriatum sinister. It appears to be pretty unrestricted. There's not really too much turbulent flow flowing through there. In the second image, that is showing color over the tricuspid valve, and it's showing moderate TR with a severely dilated right ventricle and right atrium.
So on this image, you are looking at the vertical vein connecting to the innominate vein. So we are in suprasternal short axis here, and you are seeing this red flow come up beyond the aorta and into the innominate vein here. And this red flow, like I said, is the vertical vein. And in the second image, you are seeing a confluence behind the heart that looks quite turbulent, which we saw in a couple slides ago as well behind the heart in the left side.
So this next image is still from the first echo, and this is showing that high PA view, also known as the pants view. And what this is showing is that the left upper is draining into a vertical vein, and that is that red flow that you see right under the pulmonary arteries.
So going on to the history, So on day 2, they took the kiddo to the OR, and they found the core triatriatum with partial anomalous. They found the left upper pulmonary vein and left lower pulmonary vein draining into a restrictive vertical vein connecting to the nominant vein that then connected to the SVC and then to the right atrium. So that was obviously a wrong connection because it's connecting to the right side. And then they found the right upper pulmonary vein and right lower pulmonary vein connecting normally to the left atrium. So in the OR, they ligated the vertical vein and resected the core triatriatum and closed the VSD. And after the operation, there was no murmur present. So moving on, just talking about some surgical repairs. They may repair the ASD and the VSD, and there may be some venous baffling. So what that is, it's an interatrial baffle. So in this image here, what they do is they baffle the pulmonary venous blood from the SVC coming into the right atrium through the interatrial septum to the left heart. So that pulmonary venous return is going from the pulmonary veins through the ASD into the left atrium. And this is also known as the Warden procedure. They may also, for the pulmonary vein stenosis, they may also use balloon dilation or a stent to keep the pulmonary veins patent.
So this is the second echo they did actually in the OR after surgery, after they found out it was partial anomalous pulmonary venous return. So in this first image, it is looking at the parasternal long axis, and it is looking at the size. And as you can see, it is no longer, the right side is no longer compressing that left side. It does still look a little bit hypertrophic, but not as bad as it was. In this second image, it is checking for the residual core triatriatum sinister tissue, and you are not seeing it. And then you are also seeing the pulmonary veins returning unobstructed to the LA, which you were never able to see previously.
So overall, on day 3, postoperative day 1, the patient was progressing with no concerns. On day 6, postoperative day 4, the patient was extubated. And on postoperative day 5 and day 7 in the hospital, the patient was weaned to room air, which is a good sign. And then moving on to postoperative day 6 and day 8 in the hospital, they only were concerned with the post-intubation pain, struggling during feeds, and decreasing weight, which is all something that the patient just had to work on over time.
Our patient was finally discharged day 11 of their stay, post-op day 9. How they follow this is with serial echoes, and this child had a follow-up 10 days later. What you want to look for when you do a follow-up is you want to see if the pulmonary vein has stenosis or if there is restenosis of any of them. And you also want to check the baffles for obstruction as well, if they are present. You want to look at the right ventricle size and function. You want to see if it's improving. And then you also want to get a good look at the TR jet and to help you be able to see what the pulmonary pressures are.
So for that echo follow-up, as you see in the first image, the right heart is looking much better already. They still classified it as moderate RVH, so right ventricle hypertrophy, and mildly dilated right ventricle. And then the right atrium's looking much better than it did, so they classified it as mild to moderate. And in that second image, it's that golden image showing the left pulmonary veins finally connecting to the left atrium unobstructed.
In this first image, this is showing the unobstructed right pulmonary veins connecting to the LA. And then in this second image, you are actually seeing all 4 of those pulmonary veins connecting to the left atrium, and they are all unobstructed, which is exactly what we want to see.
So there are a couple differential diagnoses that can be present instead of anomalous pulmonary veins. So there can be RDS, which is respiratory distress syndrome, where the infant is just struggling to breathe or doesn't have the lung capacity yet. There could also be a persistent pulmonary hypertension with high right-sided pressures in the heart, making the infant struggle to breathe as well. There could also be a large ASD or a large VSD. So in conclusion, we have some imaging tips. So it is very important to image all 4 of the pulmonary veins returning unobstructed to the left atrium. You may want to turn down your scale and increase the color gain because they are low flow, and you can see them in many different views, so be sure to evaluate them in every view that you can possible. The surgical repair can be treated and successful in a timely manner. So like we said earlier with partial anomalous, if you wait to take that patient to the OR, they may develop congestive heart failure. You also want to identify the associated lesions and evaluate for any residual defects. So in our patient, they identified that they had a pulmonary venous return, partial pulmonary venous return, and then they evaluated the residual defect for core triatriatum to see if there was any tissue membrane left. Then you also want to assess the right heart function, pressure, and size. And according to a really great book, Lie, total anomalous pulmonary venous return has a significant risk of recurrent pulmonary vein obstruction. And that's due to the anastomosis of all the pulmonary veins connecting back to the left atrium.
So finally, we would like to give a big thank you to Children's Hospital of Wisconsin, Herma Heart Institute, and Lindsay Thomas of University of Wisconsin Hospital and Clinic School of DMS for helping us through this project and providing us with the image and allowing us to further our education. These are our references we used. A really great reference that we love to use is PedEcho. They have a lot of very good pictures on their website, along with very simple definitions that kind of help you to understand better what pathologies you are reviewing. Does anybody have any questions for us at all?
This is Jess. I don't have any questions for you, but that was a really good job. That was a really good review. I haven't talked about anomalous pulmonary veins in a long time.
Thank you.
Thank you so much.
Does anyone else have any questions for them? Okay, in that case, I'm not sure which group is going next then.
Liz and Megan, are you guys next?
Yeah.
Okay, great.
Okay, perfect. So Megan and Elizabeth will be doing the COVID-19 and the heart. And per usual, while they're getting set up, just a reminder, the CMA survey is in the chat for anyone who may have just joined. And if you are looking for credit, make sure you use your first and last name when you log in, or change it if you haven't done so already. And then on your CME form, just make sure to include your full name, birthday, and ARDMS number. And then one other side note, while they're getting set up too, this will be the last meeting for this spring. And then the next ones won't start again until September. So it'll be September, October, and November. And Megan and Liz, it's all yours when you're ready.
Can you guys hear me?
Yes, we can.
Okay, we were having some technical difficulties, but we're all set.
Great, thanks.
All right, so my name is Megan. I'm an echovascular senior. And my name is Liz, and I'm also an echovascular senior. And we will be presenting COVID-19 and the heart. So our objectives today are to define COVID-19, to discuss how COVID affects the respiratory and cardiovascular systems, to discuss pre-existing conditions contributing to COVID-19 and heart problems, to outline a focused cardiac imaging protocol for COVID-19 positive patients, to discuss right heart quantification, and then to review some case studies. So what is COVID-19? COVID-19 is an infectious disease caused by the SARS-CoV-2 virus. The most common symptoms are fever, cough, tiredness, and loss of taste and smell. As the COVID-19 pandemic continues, we are seeing many respiratory and cardiovascular problems occurring. These symptoms and complications can range from mild to severe and include, but are not limited to, acute coronary syndrome, acute respiratory distress syndrome, blood clots, cardiac arrhythmias, cardiogenic shock, cardiomyopathy, or pulmonary multisystem organ failure, myocardial injury, pneumonia, and thromboembolic complications. We are seeing a high correlation between cardiac injury and more severe cardiac injury when patients have pre-existing conditions such as cancer, cerebrovascular disease, chronic lung diseases, chronic renal failure, coronary heart syndrome, coronary heart disease, diabetes, heart failure, increasing age, male sex, and race. Also, parents with cardiovascular disease have a greater severity of pneumonia and severe symptoms. So what we are seeing is that the COVID-19 virus attacks the lungs first, which causes inflammation and fluid accumulation in the alveoli, which then leads to a backup of blood from the lungs to the heart. So the right heart is very sensitive to pressure changes in the lungs and will then begin to dilate in response to these increased pressures. As this ventricle continues to dilate, it will then stretch the tricuspid valve annulus, which will cause tricuspid regurgitation. This regurgitation will then cause further dilation and volume overload in the right heart. So as the right ventricular volume overload will eventually cause the interventricular septum to shift into the left ventricle, which then affects left ventricular filling and contraction. Over time, the right heart volume overload will cause a pressure overload and then further cause a reduction in right ventricular contractility. Many patients who have COVID-19 require mechanical ventilation, and some require high positive end expiratory pressure to help protect the lungs. This form of ventilation causes the alveoli in the lungs to overflate, causing extrinsic vasculature compression and an increase in pulmonary vascular resistance, resulting in an increase in afterload for the right ventricle. This also results in decreased venous return, producing a reduction in right ventricular end diastolic volume and stroke volume, reduced right ventricular preload, increased right ventricular afterload, ventricular interdependence, and also a secondary reduction in left ventricular afterload. So during this pandemic, echo has become a modality of choice due to being non-invasive and portable. The cardiac problems associated with COVID-19 most commonly affect the right heart, as we discussed earlier. And as we are imaging, we should make sure to tailor our exam based on patient symptoms and what we are seeing on the exam. Some of these expected findings are decreased left ventricular function, dilated right atrium and ventricle, right heart failure, right ventricular dysfunction, right ventricular septal dyskinesis, right or left heart thrombus, and ventricular interdependence.
There was a study done by St. Luke's Medical Center that included 5 sonographers that were scanning COVID-19 patients. They created this focused protocol to limit their exposure time while scanning. The main focus of this protocol was to determine left and right ventricular function and to evaluate pulmonary artery systolic pressure. Some of the most important focus is right ventricular parameters, pulmonary artery systolic pressure, annular motion, and right ventricular strain. Each lab is going to have a different protocol for COVID-19 positive patients, but this is a great example of one and to consider implementing in your lab.
So next, because strain is part of that protocol, we're going to talk a little bit about it. So strain imaging is a tool we can use to help us quantify ventricular function. It uses speckle tracking technology, which has the proven ability to detect a decrease in systolic function before a decline in ejection fraction. When imaging for strain, we want to have good on-axis images with endocardial definition for good speckle tracking. According to the American Society of Echocardiography, the normal value for left ventricular strain is greater than -20%. And we want to keep in mind that different brands such as GE and Philips have their own tracking software, and these all track just a little bit differently, so we want to try and use the same machine when performing follow-up care.
Right ventricular strain is also very important with COVID-19 positive patients. We want a good right ventricular focused view in apicals that should not be foreshortened. We also want to show good right ventricular free wall endocardial definition. Based on the most recent guidelines from the American Society of Echocardiography and European guidelines, the septum should be omitted, so the only thing in our strain calculation should be our free wall segments of the right ventricle. And the normal value for RV strain is greater than -20%, so the more negative, the better.
So as more information is being collected, we are seeing that the right heart is more commonly affected, so that's what we are going to discuss on how to accurately assess this side. So by doing so in the right ventricle, we want to again get really good two-dimensional images so we can do measurements. We want to do these at the base and mid-ventricle in end diastole. For systolic function of the right ventricle, we want to make sure to assess TAPSE, right ventricular fractional area change, tissue Doppler imaging of the lateral tricuspid valve annulus, specifically the S prime value, and right ventricular index of myocardial performance, which we can do by using pulse wave Doppler as well as tissue Doppler. We also want to make sure that we're assessing the right atrium, and we should be doing this by tracing a right atrial area and by also measuring right atrial length and diameter. So now we're going to move to our case studies. Our first case study is in the article Acute Cor Pulmonale in a Critically Ill Patient with COVID-19 Resolved with Veno-Arteriovenous ECMO. Our patient is a 38-year-old male. He was hospitalized for 20 days with COVID-19 and his symptoms did not improve, so he was transferred to the American British Cowdery Medical Center in Mexico City, Mexico. The patient presented to their ER with bilateral coarse crackles in the lower lungs, respiratory failure, tachycardia, tachypnea, and a 75% oxygen saturation with a non-breather mask at 10 milliliters per minute. This patient was then placed on mechanical intubation, but demonstrated refractory severe hypoxemia and hypercapnia. After 12 hours of ventilation, he was then placed on veno-venous ECMO, and during this placement, a TEE was performed, which diagnosed right heart failure, and the patient was then switched to veno-arteriovenous ECMO. 3 days after this placement, the patient was then switched back to veno-venous ECMO, where he remained until it was removed. On day 30, the patient started ECMO weaning. On day 75, ECMO was withdrawn. On day 81, mechanical ventilation was weaned, and the patient was discharged from the hospital after 91 days. So during the first ECMO placement, the TEE was performed. The patient was found to have an RV fractional area change of 25%, a TAPSE measurement of 10 millimeters, an RVOT VTI measurement of 4.9 centimeters, an RA volume index of 41 milliliters per meter squared, and a pulmonary artery pressure of 50 millimeters of mercury. So during this echo, they also found right cavitary dilation, right ventricular dysfunction with akinesia of the right ventricular mid-free wall, mild tricuspid regurgitation, and the patient was then diagnosed with right heart failure and was switched to the veno-arteriovenous ECMO. So after 3 days, another TEE was performed, and he was found to have measurements of a right ventricular fractional area change of 52%, a TAPSE measurement of 22 millimeters, an RVOT VTI measurement of 23 centimeters, an RA volume index of 28 milliliters per meter squared, and a pulmonary artery pressure of 30 millimeters per mercury. This patient was now found to have normal right atrial and right ventricular sizes, as well as normal right ventricular function, and no tricuspid regurgitation was found. And after 72 hours, again, the patient was then switched back to veno-venous ECMO. So this was of the first TEE during the veno-venous ECMO placement. We can see right ventricular dilation. We can also see right ventricular dysfunction and akinesia of the right ventricular mid-free wall. So this area, and we can also see it in the short axis view here. And they also put color Doppler on the right side, and in this image we can see the mild tricuspid regurgitation, which also helped lead to the diagnosis of right ventricular heart failure. These pictures are of his measurements. So A on the left side is of his fractional area change, which was 25%. B is in the top right, and that is the RVOT VTI measurement. And C is in the bottom right of 10 millimeters for the TAPSE measurement. According to the Extracorporeal Life Support Organization registry, the modality of support in COVID-19 has been ECMO. So we're going to talk a little bit about it here. Veno-arterial ECMO is used primarily in patients with right or left-sided heart failure as a bridge to recovery or other ventricular assist devices or heart transplantation. This type of ECMO provides respiratory as well as hemodynamic support. We also have veno-venous ECMO. This is employed in severe respiratory failure as a bridge to recovery or to lung transplantation. This form of ECMO provides respiratory support and does not support cardiac function, but patients must have stable hemodynamics in order to be placed on it. And it is recommended for COVID-19 patients with acute respiratory distress syndrome. So while this type of ECMO is recommended for COVID-19 patients, especially with acute respiratory distress syndrome like our patient, he was switched to veno-arteriovenous ECMO due to his hypoxemia and right heart failure. So what is veno-arteriovenous ECMO? It represents a mixture of both veno-venous as well as veno-arterial ECMO and provides both hemodynamic and respiratory support at the same time. So this approach is sufficient to rescue combined heart and severe lung failure in selected cases, such as the patient in this case study. After the patient was placed on this type of ECMO, after 3 days, another transesophageal echocardiogram was performed, and what this demonstrated was normal chamber sizes of the right ventricle and right atrium, and the right ventricle had returned to normal function and no tricuspid regurgitation was seen. And that dyskinesia of the free wall was now resolved.
The next case study that we are going to go over is from acute right ventricular dysfunction in a critically ill patient with COVID-19. So our patient is a 67-year-old male. He presented to the emergency department with severe respiratory distress and a 4-day history of malaise, anorexia, dry cough, and dyspnea. His chest x-ray showed bilateral interstitial infiltrates with right lower consolidation. The patient required endotracheal intubation, mechanical ventilation, fluid resuscitation, antibiotics, and vasopressor support for septic shock. The patient also acquired acute respiratory distress syndrome due to COVID-19. He also had other complications during hospitalization that included acute kidney injury, liver shock, GI hemorrhage, pneumonia, and bacteremia. So because of his ongoing shock, he had an echo, and they found he had preserved left ventricular ejection fraction, severely dilated right ventricle, reduced right ventricular function, flattening of the interventricular septum, severe tricuspid regurgitation. His pulmonary artery pressure was approximately 56 millimeters of mercury, and his troponin baseline was found to be 275 when normal is less than 15. So the image on the right is a normal peristernal long axis view, and our image on the left is of our patient showing a dilated right ventricle. The image on the right is showing a normal peristernal short axis great vessel view, and the image on the left is our patient's echo showing that dilated right ventricle again. This view is our peristernal short axis view at the papillary muscle level. It's demonstrating septal flattening and diastole, which is indicative of volume overload. This is the apical four-chamber view, still showing the dilated right atrium and right ventricle. It's also demonstrating decreased right ventricular function, and at the top left portion of the image, it is demonstrating a pleural effusion. Due to complications, the patient's family opted for comfort measures and withdrawal of life support, and the patient passed away after 22 days in the ICU. And our last case is from the article Cardiac Screening in a Young Adult Male Leading to the Discovery of Post-COVID Myocarditis with Asymptomatic Large Apical Left Ventricular Thrombus. So our patient is an 18-year-old Hispanic college athlete. In September of 2020, the patient had a 3-day period of fever, myalgia, nausea, and vomiting. The patient was tested for COVID-19 and found to be positive, and no symptoms persisted after this 3-day period. In November of 2020, an elevated troponin level was found during a routine screening for athletes, and the patient was admitted to the hospital for further testing and imaging. And the elevated troponin was assumed to be due to acute coronary syndrome due to the recent history of COVID-19. So our patient had 2 kinds of imaging done. In the echo, they found decreased left ventricular systolic function, and his ejection fraction was 40%. They also found a fixed mass in the left ventricular apex measuring 5 by 2.2 centimeters, and there was also no pericardial effusion or left ventricular hypertrophy. He had a cardiac MRI done, which they found a dilated left ventricle, moderately reduced systolic function with global hypokinesis, and a left ventricular ejection fraction of 38%. His cardiac MRI also demonstrated patchy left ventricular myocardial edema, which is most consistent with myocarditis. So this image is our peristernal long axis view showing a fixed mass with mobile tail in the left ventricular apex and decreased left ventricular function. This is our apical four-chamber view, which is also supporting the findings from our peristernal long axis view, seeing the hyperechoic mobile pedunculated mass extending about 50% into the left ventricle. This is also our four-chamber view with the use of our contrast enhancing agent. So the thrombus will be shown in black, and then where the blood is shown in white. And this is demonstrating the mobile apical mass. This is our parasternal short axis view, again demonstrating the left ventricular apical mass that we can see extends into the papillary level, and this is significant because of how far it extends into the left ventricle. This is images of the cardiac MRI in two-chamber view. Image A is showing the apical thrombus adherent to the apical wall. Image B is showing mildly patchy edema within the left ventricular apex and inferior wall, which is what the black arrows are showing. And this, again, helps with the diagnosis of myocarditis. And image C is demonstrating the transmural and mid-myocardial delay enhancement, which is indicative of areas of necrosis and fibrosis. So the patient was sent home on heart failure medication and warfarin, and the patient had regular follow-ups for the progression of the left ventricular thrombus. A few months after his diagnosis, he became non-compliant of his medication and came back with a persistent left ventricular thrombus. And then after these findings, the patient was re-educated on the importance of being adherent with his medication, and he left with the continued use of his previously prescribed heart failure medication and warfarin.
So as the COVID-19 pandemic is continuing, it is also causing several respiratory and cardiovascular problems. As more data is being collected and analyzed, we are seeing that the right heart is being affected at a higher rate than the left heart, and we should remember to tailor each exam to the symptoms and pathology we are seeing for each patient.
And we would like to take time to thank our mentor, Michelle Cordio, for helping us put this presentation together and help us get our images. And thank you everyone for joining us today and listening to this presentation.
Does anyone have any questions?
Okay.
All right, thank you. Great job, ladies. So we have one presentation left. And as I'm looking down, it would be the venous insufficiency, the protocol and optimization by Megan and Yasmin. Michelle, do you, while they're getting set up, or anything from anybody from the school, do you guys have anything that you needed to talk about or address?
Nothing tonight. We are setting up a spring, well, it'll be late spring, advisory committee meeting. We'll send it out to all of our clinical instructors, so everyone should be getting an invite. So we'd really like some feedback and a few more participants this year if we can. We're doing some changes at the school, and we're adding hopefully some more students so we can better suit our community. So we'll be sending that out. I think we scheduled it for May 4th or 5th or something like that. But we'll send that out shortly. So we appreciate our community and everybody helping the students out with the case presentations. So I don't know, does anybody else have anything else to say?
Nothing on my end.
We just really appreciate everything our clinical people do for our students and for our school. We really appreciate all of you, especially the last couple of years has not been easy for any of us, and we appreciate your patience and helping them. So.
All right, well, good deal. Well, and it's always great having the students, obviously being a former one myself, you guys always do a great job, and yes, we appreciate that. And you guys are doing a great job with these presentations. I'm glad I didn't have to present like this when I was in school.
Jess, you would have done great. And your favorite thing to say, core triatriatum, right?
I almost brought that up. I was going to tell you guys. I couldn't say it when I was in school, so I did a presentation on it, so I'd have to say it over and over again.
All right, can everybody see my screen?
Yes, we can.
Awesome.
And we can hear you nicely too.
Great. All right, so my name's Yasmin Rasmussen. I am an echovascular senior. And my name is Megan Platt. I'm a general vascular senior. And today we're talking about venous insufficiency, the protocol optimization, and we have some case studies. So our objectives today are discussing updated terminology of the lower venous system, review the venous insufficiency protocol, describe waveforms of the venous system, discuss proper color and spectral Doppler optimization, how to perform physiologic maneuvers to present reflux, review measurements done during insufficiency studies, and we're also going through case studies. So this is just a really good diagram showing chronic venous insufficiency. It is caused by damaged valves in the veins of the legs, which allows blood flow to flow backwards. This disease happens in stages and without treatment can result in swelling as the excess fluid escapes into the tissue of the legs and can eventually result in varicose veins, leg pain, venous ulcers of the legs. So before we get too far into it, we wanted to go over some terminology. First up, we have the deep system. So the new name for the profunda vein is now the deep femoral vein, and the new name for the superficial femoral vein is now the femoral vein. As for the superficial system, the new name for greater saphenous vein is now the new name for the great saphenous vein is the old name for the great saphenous vein is the greater or long saphenous. The new name for the lesser short saphenous is the small saphenous vein. The new name for Giacomini's vein is the intrasaphenous vein. And the new name for the posterior arch or Leonardo's vein is the posterior accessory of the great saphenous vein. And then as for perforators, the new name for Cockett perforators 1, 2, and 3 is now the posterior tibial perforators, lower, middle, and upper. The new name for Boyd's perforator is the proximal paratibial perforator. The new name for Sherman's perforator is the paratibial perforator. The new name for the 24-centimeter perforator is also the paratibial perforator. The new name for Hunter and Dodd's perforator is perforators of the femoral canal. And then the new name for May's or Custer's perforator is the ankle perforators. And then here we just have a really nice graphic of the deep, superficial, and perforating veins showing new names and perforators showing both old and new names. All right, so some common indications for these exams you'll see are venous ulcers, which are wet, oozy, and irregular shape, and they're near to the medial malleolus. Swelling or inflammation, varicose veins, venous claudication, or described as heaviness in the legs, skin color changes like redness or brawny discoloration, pain, or preoperative evaluation. And then into varicose veins, we wanted to define those for you. They are elongated, dilated, tortuous veins, which are commonly found in the lower extremity. Some risk factors for varicose veins are older age, being female, pregnancy, occupation, so that would be jobs where a person is on their feet for a long period of time, obesity, family history, congenital abnormalities such as Klippel-Trenaunay syndrome, which is rare, and then arteriovenous fistulas.
All right, so for the exam preparation, you'll need a bed that can tilt, a footboard, a block or towels, and you'll need a linear array transducer and a curvilinear array transducer for patients with larger legs. So the first thing you'll do is insert the footboard into the end of the bed. They look something like this. This is a really fancy bed, but this is something that it should look like. You'll have the patient lay supine on the bed, and then you'll place the block or roll up a couple of towels and put it under the foot of the leg that you are not scanning first. And you'll instruct your patient to stand up or put their weight on the block or towel so that their other leg can dangle, and that will be the leg that you're scanning. You'll tilt the bed up into reverse Trendelenburg, and SVU protocol says that it'll have to be at least 15 degrees, but you want the patient to be as close to standing as comfortably possible for your patient.
So moving into the protocol, we must first rule out a DVT before performing the reflux exam. We look for a DVT before doing a reflux exam because venous insufficiency allows blood to pool in the legs, leading to varicosities and blood clots. Once the DVT is ruled out, we can evaluate the reflux of the deep veins. When doing this, we want to make sure we have a slow pulse wave sweep speed. That would be 25 to 50 millimeters a second. So that top left image A, that shows a normal femoral vein. The top right image, image B, that shows a normal femoral vein with compression. The bottom left image, C, is echogenic material seen in the femoral vein. And the bottom right image, D, is abnormal compression as femoral vein cannot fully collapse.
All right, so getting into the insufficiency part of the protocol, just like in the DVT evaluation, we will assess the deep veins for flow. For insufficiency, we'll have to ask the patient to Valsalva and mimic that reflux, and then we will do a distal augment. So we'll image the same vessels that we do for a DVT study in long with 2D color and pulse wave Doppler with that patient Valsalva and distal augment. And then to ensure our patients are doing the Valsalva maneuver correctly, I tell my patients to take a deep breath out and then squeeze their stomach muscles and bear down like they're going to do a sit-up or like they're going to the bathroom. This will stop venous return in the body, and if there is reflux, blood will flow backwards. The image on the left has no reflux, so as you can see, there's no flow antegrade. And then in image B, this is Valsalva positive, so this image does have reflux. And then continuing on with the protocol, we'll do a diameter, depth, and pulse wave with Valsalva of the superficial veins. So we'll do it at the saphenofemoral junction and then the great saphenous vein at the prox thigh, mid thigh, distal thigh, the knee, and then the proximal calf, mid calf, distal calf, and the ankle. And then we'll also do the same thing with the small saphenous vein. So we'll also do a sweep of the saphenopopliteal junction, which is shown here. And there are a couple of different variants that patients can have. So image A shows a long picture of the small saphenous vein coming directly off of the popliteal junction right here. And they're doing the diameter and depth of that. And then image B shows the small saphenous vein as an extension of the Giacomini or intersaphenous vein. So here's our Giacomini's vein or intersaphenous, and then our small saphenous continuing down. And then image C has no connection to the popliteal, and it is a continuation of the intersaphenous vein. So this has no connection to the popliteal vein. And then we'll also continue doing our diameter, depth, and pulse wave with Valsalva for the small saphenous vein at the proximal calf, mid-calf, and the distal calf. And then a couple of extra images, if it applies, of the anterior saphenous vein. Sometimes the anterior saphenous vein can look similar to the great saphenous vein, so making sure that you are on the correct vein. And the anterior saphenous vein can also become dilated and be a site for varicosities. So if it is visible, do a sweep over it and sweep for it like any other varicosities you would in these studies. And then you'll also image the contralateral CFV if it is a unilateral study, and you'll do 2D color and pulse wave.
So next I want to talk about insufficiency waveforms. We want to show the entire reflux. So that means we want to have the baseline in the middle to visualize all flow. This ensures that we will see all reflux, and then we want to make sure that we capture the entire waveform and not cut the waveform short. Wall filter should be low and appropriately gained. And then as for the duration, on the bottom image, the green arrow shows the waveform being accurately measured. That is the end of the reflux, and then the blue arrow is most likely artifact, so we would not want to include that in our measurement. As for wall filter, we want to set the wall filter as low as possible. We want to see all of the venous flow. That bottom image, we could be missing some flow just because the wall filter is set too high. And then take note on the bottom image, on the bottom of the screen, that is our correct sweep speed at 25 millimeters a second.
Okay, and this is just a really nice graphic showing the perforators of the medial side of the leg. So we're doing a transverse diameter and depth where the perforator transverses into the deep fascia. We'll do a long image of it and do a pulse wave and color with Valsalva. And you will measure the distance in centimeters from the perforator to the medial malleolus. And then this is a graphic of the medial side of the leg. And then this is a graphic of the lateral or posterior side of the leg.
Talking about perforators, this diagram here shows the dynamics of a normal perforators, dynamics of normal venous flow in response to calf muscle contraction in a normal limb. At rest, blood is still moving, but at a slower rate. Valves keep blood from moving away from the heart. Calf muscle contraction causes a slight compression of the veins, and distal valves close, so blood does not flow retrograde. The red circles are showing closed valves during contraction. This graphic shows incompetent valves, dynamics of venous flow in response to calf muscle contraction in a post-thrombotic limb with residual deep venous obstruction, incompetent valves, and secondary varicose veins. Blood flow in perforating veins is bidirectional. Again, at rest, blood should still be moving, but at a slow rate. When calf muscle is contracted, incompetent valves cause retrograde flow. The red circle shows an open valve allowing the blood to flow backwards during contraction.
All right, and then here is just an example of a perforator sweep. So if you look at the green arrow on the left, it is pointing to the deep fascia, and this is where you can see the perforator come down. So you'll see it come all the way down past that deep fascia. And then here is just a graphic of that, showing the same fascial plane and the perforating vein crossing the deep fascia into the deep venous system. Next, we're going to talk about 2D image optimization. So this image on the left is a little bright and it is hard to make out the walls of the vein, and it could lead to an inaccurate measurement. Whereas the image on the right is nice and dark, and we can see that the vessel is hollowed out, and you can clearly see the vessel lumen for measurement. We can also tell that this is the GSV and a superficial vein because of the layer of fascia around the vessel, and that is the superficial fascia.
Going into color gain optimization, the first image is overgained and looks like there's extra vessels that are not actually present due to color bleeding artifact. You want to make sure the color box is going in the correct direction. Perforator flow should be blue because it is traveling from the superficial to the deep system, which is away from the transducer. Spectral Doppler optimization. The first image is overgained. You want to turn down the gain to make sure you're not getting any artifact. It looks like we are getting flow when it's not actually there. You also don't want to see any nearby arterial flow.
And with that, let's get on to our first case study. So case study 1, this is from an article called Sonographic Evaluation of Chronic Venous Insufficiency in Right Heart Failure. This case study consists of 3 patients with varicose veins and venous ulcers with associated tricuspid regurgitation, or TR. All 3 cases were misdiagnosed as arteriovenous fistulas, and all received a duplex scan, which confirmed right heart failure. So the pathology behind this is that in right heart failure, the right heart does not pump as well and it'll dilate, causing the valve to be pulled apart from its coaptation point, resulting in tricuspid regurgitation, causing the blood to back up into the body and causing congestion. This congestion can affect the liver, GI tracts, and the lower limbs. With severe enough TR, the pulsation can be felt in the liver and the lower limbs. And in the lower limbs, the pulsation felt in the veins can mimic an arteriovenous fistula, and that's how these patients became misdiagnosed. So showing a normal hepatic vein. So on the left, these are normal hepatic veins showing diastolic flow reversal in the hepatic veins due to atrial contraction. And then the image on the right is from our case study, and you cannot see A, S, and V. They're basically indistinguishable due to right heart failure and tricuspid regurgitation. Next, this is a normal IVC flow imaged on the left, and then our case study image on the right shows this to and fro flow. So it's not as it's not as respirophasic, and it is giving more pulsatile waveform. So patient 1 is 82 years old, a female. Only the right limb is affected and is presenting with venous ulcers and a pulsatile GSV to the mid-calf. The echo showed tricuspid regurgitation, and the patient declined operation but was being managed with pressure therapy. After an 8 months follow-up, they are continuing therapy and their ulcers have healed. Patient 2 is a 93-year-old patient. She's female. Our right limb was affected. Presents with ulcer edema and pulsatile GSV varicosities. The echo showed tricuspid regurgitation and right heart failure, and the patient was being treated with compression therapy. After 6 months of 6 months follow-up, they are continuing therapy and their ulcers were also healed. Patient 3 is an 87-year-old man. Only the left limb was affected, presenting with acute cellulitis, edema, venous ulcer, and a pulsatile GSV to the mid-calf. This patient was treated with a saphenofemoral ligation, which is shown in the graphic to the right. And it is done by the vessels simply being tied off. And 2 months follow-up, he has significant healing of the ulcers and resolution of cellulitis and edema after the procedure. And then here is just what a normal GSV flow is. GSV flow should be respirophasic and spontaneous. And the image on the right is from our case study, and this is abnormal. It is pulsatile, and it is not respirophasic or spontaneous. So overall summary for this case study is pulsatility of the GSV is abnormal and suggestive of cardiac influence on the vessel, and that venous Doppler is a helpful tool in the examination of suspected right heart failure in chronic venous insufficiency.
Moving into the second case study, we have a 38-year-old female, G1P0, which means she's pregnant for the first time and has not yet delivered, meaning she has no children. She's at 32 weeks gestation. She's experiencing persistent left lower extremity edema. She has a 1-month history of left leg pain and swelling after a long car trip. And she has 3 negative lower extremity ultrasounds from outside ultrasound imaging facilities over the previous month. Patient findings: she's having continuous flow in the left common femoral vein. The right common iliac and external iliac demonstrated spontaneous and phasic flow. The left proximal common iliac and external iliac demonstrated continuous flow. And there's a near occlusive DVT found in the enlarged left distal common iliac and common femoral vein. So these are images from the case study. The image on the left shows the right common femoral vein, which demonstrates little spontanicity and phasic flow. Dropping the spectral scale would improve the waveform. And on the left, or the right image, the left common femoral vein, this suggests, or there's continuous flow in the left common femoral vein. This suggests a more proximal obstruction or extrinsic compression of the vessel. You want to note the color flow in the left common femoral vein. The bottom of the vessel is not filling, along with some hypocuc echoes. This is suggestive of an acute thrombus. You want to perform a compression to be sure. So due to the findings in the left common femoral vein, the IVC was interrogated and demonstrated spontaneous and phasic flow, as well as the right common iliac vein. The left common iliac was found to have extrinsic compression and demonstrated continuous flow and elevated velocities. You want to note the aliasing and high velocities of the continuous waveform in the left iliac. Extrinsic compression from the fetal head and a uterine fibrin was found on the left common iliac vein. The patient was right lateral decubed to relieve compression of the left common iliac and to further image the left common femoral vein. Thrombus was shown in the left femoral vein, and then they performed a compression. So a summary of the second case study: a near occlusive DVT was found in the left common iliac and left common femoral vein. Extrinsic compression from the fetal head and uterine fibroid factors added compression to the vein, causing it to be occluded. Extrinsic compression in a long car trip attributed to venous stasis. Stress on the vessel by the compression caused endothelial injury to the vessel, and pregnancy changes the plasma of the blood, increasing clotting factors. These 3 factors together are known as Virchow's triad, which is venous stasis, endothelial injury, and hypercoagulability. We want to give a special thanks to Michelle Cordio and the School of DMS for helping us find quality resources and taking images for this presentation.
And here are our references. Does anybody have any questions?
Okay, any last questions for any of the groups if they're all still on? In that case, thank you all so much. You guys did a really good job. You should all be really proud of yourself with those. And then last reminder, the CME link is in the chat group. Just make sure it's first, last name, date of birth, and ARDMS number. And then again, our next meeting won't be until next fall. So September, October, and November. It'll still be the second Monday of every month from 5:30 to 7:30. We do have a lot of the speakers already planned, so you can always go to the website, take a look if you're kind of curious about what's coming up in the fall. And other than that, I hope you guys have a great summer.
Thanks, everyone.